This is a nice little example of a sleep log. This is available to you at one of the links I'm providing at the end for you as well. You can download this for free. Sleep log, sleep diary. These are very essential in helping you sort out what kind of sleep problem a patient is having. When it comes to treatment, what I want to ask you is a pill really necessary? And I will tell you that by and large, most of the time in the geriatric population, it's not only unnecessary, it's simply not a good idea, especially if we go the route of the traditional sedative hypnotics, and for reasons I'll discuss. Falls, ataxia, reduced cognition, these are medications that are supposed to help people sleep well, but guess what? They don't. If you're here as a caregiver and you have a loved one on these particular medications, it really warrants a good review. Have someone sit down with you and look at what's happening in your loved one's sleep and determine, could this medication be the cause? There's a huge disruption in sleep architecture. So we're giving a sedative hypnotic to get people to sleep, and guess what's happening? They're not sleeping very well. They have a reduction in slow wave sleep, here again. Reduced REM. If they have a sleep disordered breathing problem, guess what? We've now just made that problem worse. So ask yourself, is a pill really necessary? I like this cartoon a great deal. Here we have a little boy in front of a big screen TV. Ask your mother if this medication is right for you. We're living in a culture to expect that. We want a pill for everything. I can't tell you how many times when I was working outpatient in internal medicine and diabetes, a person would come in and tell me, I want the purple pill. I want this pill, the butterfly. I want the pill that gives me the butterfly flying into my room and helping me sleep at night. Marketing works. And if you want to hear some really great criticism of our pharmaceutical industry, and I think they deserve good criticism, is the work of Andrew Weil. And he's written several books. And he said, you know, there's two countries that advertise directly to the public, the United States and New Zealand. And we're one of the highest consumers, if you look at those two countries, and we're certainly the highest around the world of the consumption of pills. There are FDA-approved medications, benzodiazepines, non-benzodiazepines, and the melatonin receptor agonists. I'll discuss them briefly. This is the take-home point. Just because it's FDA-approved doesn't mean it's good for you. Just because it's FDA-approved doesn't mean it's safe for your geriatric patient. In fact, it frequently is not. Well, these are the benzodiazepines that are FDA approved for sedative hypnotics. I have never prescribed them. I never will. Many of these, if not all of these, in my opinion, now this is a Julieism. This has not come from the research. I think really should be taken off the market, but that's my opinion. The rest, I'm going to tell you the literature and what the research says. Well, how do they work? Well, they enhance GABA, gamma-aminobutyric acid. That's inhibitory. That's how sedative hypnotics works. So that makes us calm, that makes us sleepy. The majority of the neurons in the brain are not GABA, by the way, they're glutamate. Glutamate, they're excitatory, responsible for our learning, responsible for our memory, our conscious awareness. 66% of the neurons in the brain are glutamate. These medications turn those neurons off. Now, I don't know about you, but if 66% of my brain is excitatory, I don't want them off. I want to keep them on. So it makes common sense that we need to be thoughtful about these medications. None of these are recommended for use in the geriatric population. Newer on the market, this is one of my favorite topics now, too, are the non-benzodiazepine class of drugs. These particular drugs are called non-benzodiazepines, but I would tell you, do not be fooled by that title. Since they've been on the market, what has come out clinically is that they are functionally very much like benzodiazepines. They're highly addictive, like benzodiazepines, for many people. They can cause falls, ataxia, reduced cognition, all of our personal favorites. We've actually also identified an addiction withdrawal pattern with these medications. So if a geriatric person is on them for a length of time, and it's highly individualistic, but let's say 6 months or a year, maybe they're taking their Ambien or their Lunesta or their Sonata, and they suddenly stop. We're seeing an acute phase of the withdrawal. So we're seeing individuals who have seizure activity and a lot of anxiety, and it's, it's that kind of anxiety, that fretfulness, that can't quite pinpoint, well, are you anxious? What are you worried about? Well, I don't know, I just feel this way all the time. You want to think about these medications, this class in particular. We've also identified a chronic phase of withdrawal from these medications. In our geriatric population, these signs of withdrawal can last up to 8 months. That kind of fretful anxiety, depression, and rebound insomnia. We're also seeing dream-directed enactments, such as sexual assaults, sleep driving, sleep eating, and so forth. If I didn't make the point that these are medications not a good idea or should be used with extreme caution and highly judiciously, let me illuminate this further. Well, this is a picture of a brain from the National Institute of Drug Abuse. And this is the pathway of addiction in the brain. This could be a conference just by itself. But the VTA is the ventral tegmental area, which is rich in dopaminergic pathways and dopamine neurotransmitters. And these lay the pathways to the nucleus accumbens and then to the frontal prefrontal cortex. This is the pathway of drug-seeking behavior. So this is where opiates work. This is where benzodiazepines function. This is where cocaine and heroin and methamphetamine work. Well, guess what we know about the non-benzodiazepines? This is where they work. Dopamine, if you remember in nursing school, what is that? That's the pleasure-seeking neurotransmitter. Gotta have it, gotta have it, gotta have it. And I'll do anything to get it. Even though I know it's not good for me, I'm gonna do it anyway. So this is the pathway, and that's where these drugs work. If you're going to insist on using them or prescribing them, then you want to be extremely judicious with their use. You've got to match the drug with the type of insomnia the person's experiencing. The short-acting drugs, Sonata and Ambien, obviously for the people with initial insomnia. These are the people who have difficulty getting to sleep, etc. The longer-acting for people who have trouble staying asleep. My feeling is this, I'm a geriatric nurse practitioner. My feeling is I'm not going to prescribe them. I think it's the wrong thing to do for the patients I see. If you feel like this is worth looking at though, you know what, and I'm perfectly willing to have a conversation with people about it, I'll say, you know, I'm going to have you see Dr. So-and-so. And you can have a conversation with this. Maybe it's right for you in this particular situation. But by and large, in the geriatric population, we really want to avoid them. One drug that you can have a conversation with patients and families about is the melatonin receptor agonist. I say that, however, with caution. It has not been out that long. So as we have found, when drugs come out on the market, they're told to us, oh, they don't do this, they don't cause that, and then of course we work with these medications and clinically we see all kinds of things. So the jury's still out on Romeltion, which is Roserum. Sleep onset, it's supposed to be very good for that. But headaches, dizziness, and somnolence the next day, kind of fuzzy hangover is very common. What I would have you consider, though, is just plain old melatonin. There's actually quite a bit of literature over the counter from a health food store, for example. Very effective for many types of insomnia, 1 to 3 milligrams POQHS, and you titrate it up. You might start the patient at 1 milligram POQHS per week, then go up to 2 milligrams, etc., up to 3. There's also a liquid melatonin on the market now, very good for patients with dementia, and they have trouble swallowing, they have dysphagia, etc. This is a very good choice as well. Very low doses, just 0.25 mils, less than 1 milligram in the liquid form, can be very effective.
What happens if you take melatonin and it makes you hyper instead of
The question that's being asked, this is a very good question on the front row, is what happens if you take melatonin and it makes you hyper? What I would tell you is this: stop taking it.
What caused it to react differently?
The question is, what would cause it to react differently? And I really couldn't begin to say in this situation, but I would speculate that it's probably a drug-drug interaction. It could be that a very thorough medication review is needed in order to ascertain what's going on. Is it a drug-drug interaction? Or maybe there's a new chronic condition that's manifesting that's not being recognized. Good question. Well, here's another slurry of medications that's often used for sedation: antihistamines, antidepressants, one of my least favorite, trazodone, which is Deseril, antipsychotics, and anticonvulsants. As a general rule, these are classes of drugs that we should avoid using for the purposes of sedation. They do have their purposes, it's just not good to use them for sedation. And basically, the National Institute of Health came out with their summative comment, which is, don't use them in the geriatric population. Particularly, the risks outweigh the benefits. Well, I like this cartoon too. This was one of my favorites now. I'm hooked on painkillers, the patient says, and the doctor says, I can give you a pill for that. Well, it's not just patient expectations that set us up for prescribing, and I've done it too. Working in a busy outpatient clinic, guess what I do? I'm writing 5 minutes into the visit. It's not a good idea. And it's based, we do it that way because this is an acute care model. Not a good way to handle or treat geriatric patients with chronic conditions. So providers get into the mindset of prescribing too, and we need to resist that temptation. When it comes to prescribing, however, I'm going to talk to you about 3 drugs that are worth your consideration if you're going to prescribe or to teach your patients about these drugs if you're working in a team and you're working as a nurse and you want to educate the patient and the family about them. Okay. Well, one of my favorite researchers is Andy Crystal out of Duke University, and I was fortunate enough to actually work with him a number of years ago and receive some of my training with him. Really a very brilliant guy. And he was the one who came out with the idea of taking a very old tricyclic antidepressant called doxepin. And he said, you know, why don't we put that in a very low dose? He started his study out with 1 milligrams and found we've really cleaned it up. What's the problem with tricyclic antidepressants? You might remember in nursing school. Oh, very good. The question is about hypotension. Very good. They're anti-adrenergic, so they affect the cardiac conduction system, which is why we usually do 12-lead EKGs before we start. American Family Practice says if the patient's 40, you do a 12-lead, etc. Okay. They're also anticholinergic, so the dry mouth, urinary retention. So with men with benign prostatic hypertrophy, not a good choice. And so we got away from the tricyclics because of these nuisance side effects and sometimes adverse events that occur. Well, doxepin or Sinequan in a very low dose, and the recommendation now is 3 up to 6 milligrams PO/QHS, is worth considering for the general treatment of insomnia in the geriatric population. It's considered safer. Why? Because it's just hitting the histamine 1 receptor. It's completely bypassing the anticholinergic receptors and anything that's anti-adrenergic. So it's just hitting H1, which is what's causing sedation. So this would be worth you considering in working with your patients. Well, 2 more that are my personal favorites, and I've prescribed them a lot, and we've had good luck in our practice here in long-term care. And the first is gabapentin or Neurontin, and that's classified as an anticonvulsant. Very good choice if the person is waking up in the middle of the night because of neuropathic pain. Neuropathic pain is a result, for example, diabetes. And they wake up, they're uncomfortable, they get up, they move around. 100 milligrams PO/QHS is a good place to start. You've got to be very cautious because it's renally excreted, so we have to monitor BUN and serum creatinine. One of the geriatric authors and researchers that I read about that was looking specifically at gabapentin, Neurontin, made the following comment.